and her chief areas of interest are in critical care, teaching, and training. Over to you, ma'am. It's indeed a very, very important topic for the postgraduates.
Thank you, ma'am. I'll be presenting.
I welcome the audience to my session today. I'm Dr. Nymphia Kaul from Department of Anesthesia, Sanjay Gandhi Hospital. Today, I'll be talking about obstetric emergencies. Now, obstetric emergencies are life-threatening conditions which occur in pregnancy, during labor, or after delivery of the baby. And if adequate measures are not taken, it can become life-threatening. Even though we deal with most of these emergencies, but an anesthesiologist is always a part of a team which is called to control the bleeding and resuscitate the mother. Now, of all the emergencies, most commonly obstetric hemorrhage is the end result, and we have to deal with hemorrhage in order to resuscitate the mother and control the bleeding. Even though about 500 ml of blood loss after normal vaginal delivery and 1000 ml after LACS is common, but anything more than that is considered an obstetric hemorrhage. And WHO has added the definition of it occurring within 24 hours of delivery. There have been some other definitions as well, like need for 4 or more RBC units, more than 50% of the loss of blood volume is considered as a large obstetric hemorrhage. But a massive hemorrhage is when there's loss of more than 25 ml of blood or 80% of the blood volume with signs of shock, coagulopathy, or need for invasive procedures. Now, why is it different from the rest? We have seen that whenever we are called, we have noticed that this bleeding is usually very sudden and rapid and is usually not anticipated and occurs first time on the table only. Then the estimation of blood loss is difficult because the clinical signs are masked by the physiological changes of pregnancy, and there may be the blood loss which is maybe mostly concealed. Most of the time we are taking up these cases without lab tests. Then there are other comorbidities which worsen the situation, and early coagulopathy sets in because of the changes of pregnancy, which is already a hypercoagulable state. Then this is something which is practiced all over the world in different kinds of centers having different facilities. So we have to deal with emergencies at different levels. If we talk about this bleeding, which is the end result of most of these conditions, what are the causes? The causes can be antepartum bleeding, which occurs after 24 weeks of pregnancy. The most common causes being placenta previa, abruptio placentae, trauma, or uterine rupture. Then the causes of postpartum bleeding is bleeding after delivery of the infant, and you have to remember the 4 T's, that is atony, retained placenta, tears or lacerations, and coagulopathy. Sometimes both these conditions will lead, we can also see intrapartum hemorrhage, which occurs right on the table without any underlying condition, and it can occur due to uterine rupture, low-lying placenta. A grand multipara can bleed a lot on the table, placenta previa itself, any previous surgeries, or uterine anomalies. If we talk about each condition in brief, we'll see that placenta previa, it is a condition where there's abnormal presentation of placenta before the presenting part, either partly or wholly covering the internal os. It is seen in 1% of term pregnancies and is associated with multiparity, increasing age. In this, mostly the patient has painless bleeding, a PV which may stop on its own. And the good thing about it is that 95% is diagnosed on routine ultrasound. When such a case comes to us, the anesthesia considerations are that it's usually diagnosed pre or by ultrasound, so that is an advantage to us. And the blood loss varies from high to low. However, risk of intrapartum hemorrhage is very high because the surgeon may cut through the placenta. Then there is a high risk of placenta accreta, and the uterus may fail to contract, causing PPH because the placenta prevents contraction of the lower part of the uterus. Or the patient may herself come in a cardiovascular compromised position. So you have to be aware of all these positions even if the patient is not bleeding pre-op. The kind of anesthesia which has to be given, if the patient has no active bleeding, is hemodynamically stable, it's an elective surgery, it can be done under spinal anesthesia. The advantages being that it avoids the complication of general anesthesia. But even during spinal anesthesia, you have to plan for severe bleeding intraoperatively. You have to keep your packed RBCs ready. If they're not available, type specific, keep O negative ones ready. And the surgeon should ensure that the cord is clamped fast, the fetus is delivered rapidly, and he avoids the placental area. All this is done to prevent exsanguination of the uterus and to prevent fetal hypoxia. And start oxytocin early at the rate of 5 units per minute. However, whenever oxytocin is given, please titrate the effect. The second method is obviously the general anesthesia. It is done when the patient is active bleeding or is unstable hemodynamically. Again, adequate blood and products should be available in the operation room. And rapid sequence induction with succinylcholine and induction agent is ketamine, 1 mg per kg would be very good. Start nitrous oxide till delivery of the baby, and once the baby is out, please be aware that any kind of hemorrhage intrapartum and postpartum can occur. However, those with massive bleeding, they may need a rapid infuser, a fluid warmer, and invasive blood pressure monitoring. And oxytocin infusion is again to be started early in these cases. And you have to be prepared for massive blood loss, so be aware. Another condition which we commonly see is abruptio placentae. This is a condition where there's separation of placenta from the decidue of endometrium after 20 weeks of pregnancy. The cause is mostly unknown, but there's a high incidence with high parity, uterine anomalies, PIH, or cocaine abuse. So the bleeding occurs from exposed decidual vessels. Here, abdominal pain is a cardinal feature. The bleeding is associated with pain, and it's usually concealed and difficult to assess. The patient usually comes in a condition of shock, has low platelets, low fibrinogen, and high partial thromboblast in time. Or the patient is herself present with ARF or DIC, that may be the presenting feature. And there's a high incidence of fetal demise. So you have to be aware that even if there's no history of blood loss in this, the blood loss can be concealed, which is an important feature, or ARF or a coagulopathy. Now, when anesthesia has to be given to such a patient, please be aware that bleeding is usually occult and difficult to estimate. Patient has hypotension, there's high fetal and maternal morbidity and mortality, high incidence of coagulopathy, and significant comorbidities are present like PIH. Again, it can cause worsening of the situation with PPH due to inadequate contraction of the uterus, and that bleeding is exaggerated by coagulopathy. So the anesthetist should be aware of all these conditions when it comes to abruptio, and the aim is early delivery of the fetus. Here, general anesthesia is usually the method of choice because patient usually comes in a state of shock. Again, rapid sequence induction with ketamine, 1 mg per kg, and succinylcholine is done. Thus, anesthetist should be prepared for PPH, and in this case, early use of FFP and platelets is indicated. Sometimes uncontrolled hemorrhage may need an emergency hysterectomy. So in all these conditions, blood should be readily available. Another condition is the placenta accreta spectrum. Now, this is any condition where the placenta adheres, invades, or penetrates the myometrium. The problem with this kind of spectrum is that most of the patients remain undiagnosed and they present as massive bleeding on the table. Routine ultrasound which has been done, if it shows vascular lacunae more than 1 centimeter, it raises a suspicion of this placenta accreta spectrum. If so, MRI is the best diagnosis, and there's a loss of clear zone between myometrium and placenta. As far as the placenta accreta syndrome is concerned, the universal management consists of cesarean hysterectomy. It's only in very small cases where conservative methods can be tried, where there are small focal areas of accreta, or if the centers are very advanced and there's facilities for internal iliac artery balloon insertion, embolization, or ligation. This will help to devascularize the pelvis after delivery of baby to decrease the blood loss. These cases are done under general anesthesia. Mostly, SA may be considered if the patient has no coagulopathy, is a planned case, is hemodynamically stable, but the best choice would be a general anesthesia. And in all these cases, we have to be ready with a massive hemorrhage protocol. When the accretive syndrome is pre-diagnosed on MRI or suspicion, you have to plan for delivery. There's no other way around. And the optimum time is to individualize around 34 weeks. There should be early involvement of other teams and senior doctors because this is a multidisciplinary approach, and blood products should be available in the operation theater. There should be contingency plans ready for any emergency delivery or any untoward massive hemorrhage. In centers where it's possible, an ultrasound on table is advantageous. This helps to confirm the position of the placenta so that the surgeon does not cut through the placenta and decreases the incidence of blood loss. Again, if there is any plan to you can do triple P maneuver where there's peri-op localization of the placenta. Pelvis devascularization is done with the iliac artery embolization, and then placental non-separation and removal of myometrium is done. All these is done in higher centers where the patient is pre-diagnosed as PS. But this undiagnosed, unexpected placenta previa is the most common presentation. So the only way to is to have a high or low suspicion based on the ultrasound findings. And it is seen that in 35% of the cases, it's usually diagnosed on the OT table where the patient does not know about it before. So you have to be well aware of the surgical procedure. Adequate blood should be present in the OT in all high suspicion cases, and a multidisciplinary approach is helpful. When such a patient is seen on the table, what happens is that there's torrential bleeding when the surgeon tries to pull out the placenta. If such a condition is discovered on table, best is to leave the placenta inside, arrange for more blood, more staff, more seniors, more experienced staff, and then proceed. Mostly cesarean hysterectomy is done, but even then it can get prolonged and large volumes of blood can get lost. During the time when all these measures are being taken, maneuvers like manual compression of aorta against the vertebral body, internal iliac artery ligation, they can all be considered. So another condition is the uterine atony. This is a major cause of PPH in our country and all over the world. This cause of PPH can be primary, which occurs within 24 hours of delivery, or it can be secondary, which occurs after 24 hours to 6 months. Anesthesiologists mostly have to handle the primary PPH due to uterine atony. This atony remains the most common cause of PPH. This can be due to a retained placenta, failure of uterus to contract due to multiparity, large baby, polyhydramnios, or any other such condition. And in total atony, the patient can lose about 2000 ml of blood in just 5 minutes. So in this, the common way is you have to resuscitate the mother. At the same time, you have to take blood replacement measures, which I'll talk about a little later. And what is different in this is that you have to use uterotonics at an early stage. So different uterotonics are used. Oxytocin, which is given as 5 units over 5 minutes, followed by 10 to 20 units as infusion. Always titrate the dose while giving oxytocin and stop it when the desired effect is achieved. Because it is a negative inotrope, there's vasodilatation and fall in blood pressure, and ST changes can occur, so you have to be careful while giving it. Onset is in 2 to 3 minutes and it lasts for 30 minutes. Second drug used is ergometrine. Even though it's not routinely used now, you give 250 to 500 micrograms slowly IV or IM. It can cause nausea, vomiting, rise in blood pressure, coronary spasm. So it's contraindicated in PIH, ischemic heart disease, or pulmonary hypertension. Prostaglandin E1 analogs like mistoprostol can be given. It is given as 800 mg oral or sublingual, can be given pervaginally, but when excessive bleeding PV is present, it's usually not used by that route. It can cause shivering and transient rise in temperature. Another commonly used drug is prostaglandin F2 alpha analog carboprost. This is given as 250 milligram IM and repeated every 15 to 30 minutes. This can cause bronchospasm, so it's not given in an asthmatic patient. Another common problem that we have to face is manual removal of the placenta. The procedure is painful and invasive, and if uterine inversion is present, you have to repose the uterus back before attempting the removal of the placenta. Just remember this. And most of the time, the surgeon will ask for uterine relaxation, and it is done with inhalation agents and not with succinylcholine, because succinylcholine is a skeletal muscle relaxant and will not be able to help the surgeon. Now, when it comes to choice of anesthesia and obstetric emergency as a general, we can have clubbed it as together. I've clubbed this together. If somebody asks about the choice, there is no absolute choice. Spinal subarachnoid block is good in a planned surgery where the patient is diagnosed well in advance, patient is hemodynamically stable, there's no evidence of coagulopathy or any other contraindication to the block. And general anesthesia is a choice when the patient is active bleeding, is hemodynamically unstable, and then it becomes the choice so that you can control the patient's respiration and the CVS. In all the cases, it is important to do pre-anesthesia assessment of the condition of the patient. For that, the lab tests can be varied, many, but what have to be done in all the cases is hemoglobin, blood grouping, cross-matching, and coagulation studies. These include PT, INR, APTT, fibrinogen levels. It would be a good idea to assess the prenatal risk to mother and fetus, because most of the time we encounter this bleeding unknowingly, suddenly on the table. So always be aware that this mother can have a risk of bleeding, and the factors which will help you to assess them are these. You can assess if the patient has prior uterine operations, multiple gestations, prior history of obstetric hemorrhage, a large myoma, or hematocrit less than 30, the patient has a fairly good chance of getting uterine PPH. However, if she has placenta previa, suspected accreta, platelet less than 40,000, bleeding is already active, or there's a known coagulopathy, then the risk of bleeding are very high. Again, when you're assessing this patient to be taken up for further management, you assess the amount of blood loss. Because as I said earlier, this is usually underestimated because the clinical signs are masked. Patient already has tachycardia and changes in blood pressure due to the changes of pregnancy. So they may be masked, and you will not realize till a very late moment that the patient has had significant blood loss. Also, the uterus can hold a large amount of blood before it becomes evident, then it becomes mixed with amniotic fluid. So you may not be able to assess the exact amount of blood loss. And to assess, they should have a high degree of suspicion if the systolic blood pressure is less than 90 millimeters of mercury, the heart rate is more than 120 per minute, urine output is less than 0.5 ml per kg per minute, and capillary refill time is more than 5 seconds. All these indicate that the patient is in a state of shock. So in any such case, generally, first thing to do is call for help. You need to more senior staff, you need people from all other disciplines may be needed to help the patient. Then you have to take care of the actively bleeding mother. She may need resuscitation. You'll have to do a good intra-monitoring of both the mother and the fetus. If possible, maternal weight can help in assessing the amount of blood loss. For example, if a 60 kg female has about 5,000 ml of blood and she loses 750 ml, that would be around 15%. If she loses 1500 ml, that is around 30%, and 2000 will be 40%. This will give a good indication of the amount of bleeding that she has had. Once you encounter such a mother, first thing you may have to resuscitate her. insert a large bore cannula, 14 or 16, usually 16 is available in OT. Carry out the ABCD of resuscitation. Start oxygen by mask 10 liters per minute and make the patient supine with a wedge. Keep the patient warm and ask for blood immediately. Till blood arrives, you'll have to give about 2 liters of ringer lactate which are warmed. Do not use blood filters because they decrease the rate of blood flow. Monitor all the vitals, and in the meantime, the surgeons may have to take action like uterine massage, oxytocin, carboprost, and repair of tears. The fluids which may be given before the blood arrives, resuscitation with these should begin early, and they should be warmed. Mostly crystalloids are used, ringer lactate or normal saline, because they are easily available, they're cheap, do not alter hemostasis or renal function. But the disadvantage is that only 25% is retained in the circulation. Colloids can be used like hydroxyethyl starch, gelatins, human albumin 5%. They are retained in the circulation for a longer time, but they're not very good in these cases because they interfere with coagulation studies and they inhibit platelet aggregation. Patients should be monitored strictly during this time. The vitals, the urine output and body temperature. Amount of blood loss is to be monitored by looking at the site and all over the suction, etc. If the patient is in shock and the center has the facilities, invasive blood pressure should be monitored. However, an easy bedside test is the capillary refill time, which is normally less than 2 seconds, but in a state of shock, it can go to more than 5 seconds. Coagulation tests are done by PT, INR, and fibrinogen, and if they're advanced centers, then point-of-care tests like ROTEM and TEC can be done. Another important aspect is blood replacement. Now, this is the cornerstone of therapy of any obstetric bleed, because in these bleeds, coagulopathy is an early feature, especially in abruptio and even otherwise also. So best is the group compatible blood, but if nothing is available, you can give uncross-matched O negative blood. Now it is important to add the blood components like platelets and FFP. Ideal is in the ratio 1:1:1. This is known as hemostatic resuscitation, and this helps to prevent coagulopathy. Or if you don't have it all together, you have to give FFP in the same ratio as RBC, or around 12 to 15 ml per kg. Platelets to be given if the count is less than 50,000, and cryoprecipitate if fibrinogen is less than 1 gram per liter. During all this, there have been some theoretical strategies also, like they are called blood conservation strategies. One is autologous blood transfusion, which is usually not practiced because the patient is already anemic in a pregnancy and it's not proper to collect enough blood. It may not be possible to collect enough blood and we don't know how much he'll bleed. Second is intraoperative cell salvage. Again, it's not routinely done, even though a lot of blood is on the table or in the abdominal cavity, but it is contaminated with amniotic fluid and fetal RBC. So both these are usually not done in the bleeding parturient, but exception is a mother who is a Jehovah's Witness. Uterine artery embolization is another method to stop the massive torrential bleeding. And this was introduced as part of treatment in obstetric hemorrhage in 1979. Now, wherever it is practiced, there has been very good improvement in results. And the advantage is that bleeding is controlled and at the same time, the reproductive function is preserved. However, the disadvantage is that difficult to transfer an actively bleeding patient with an open wound to the radiology suite, and it is available only in advanced centers. This is another therapy which was tried, but it was first developed for patients of hemophilia and reportedly used for PPH in 2001. It is not used routinely, but may be used as an adjuvant to standard treatment under guidance of a specialist. The dose is 90 microgram per kg, which may be repeated in 30 minutes. However, the prerequisite is that fibrinogen should be more than 1 gram per liter and platelets should be more than 20,000 because it acts through these only. Another disadvantage is that it's quite expensive. While all this is being done, blood replacement, assessment, monitoring, please remember to take all other measures to bring a positive outcome. First of all, keep the patient warm, maintain strict asepsis. This can take a hit because so many people are working on the patient. So it is important to do this. Then monitor the ABG and control the acidosis, because hypothermia and acidosis are one of the major factors which contribute to the negative outcome. One important drug is tranexamic acid. This has been recommended to be used in all obstetric hemorrhages because it inhibits fibrinolysis, and early use is recommended. You give 1 gram or 10 to 15 milligram per kg IV and can be repeated after 30 minutes. At the same time, try to correct all the electrolyte abnormalities, as potassium and calcium are commonly deranged during this process. While taking the measures, the goals of resuscitation should be hemoglobin more than 8 grams per deciliter, platelets more than 75,000, PT of less than 1.5 times of control, fibrinogen more than 1 gram per liter, and you can also do permissive hypotension. This is a new concept where it is said that there's no need to overload the body with fluids, because that has more of a negative impact than a positive impact, because it causes dilutional coagulopathy and can increase the bleeding. So till the blood arrives, do not overload. Keep the BP around 90 millimeters systolic and permit some degree of hypotension. This will cause less bleeding and is seen to be more beneficial to the patient. At the same time, because this bleeding is usually unanticipated, you should have a center may have massive transfusion protocols. What happens is that wherever these are present, if they are present in centers which handle large trauma, this protocol facilitates the request and transport of large quantities of RBC and blood components to the patient's site, because it improves the communication of the blood bank. And what happens is that when you give such a call, it delivers a set quantity of blood in response to a single call without lengthy paperwork. So there'll be 6 units of O negative packed RBC, 4 to 6 units of FFP, and 1 large platelet unit, all delivered together to the operation site. If this is present, this helps in rapid transport of components to the table. Having said all this, all the steps to be taken, the practice recommendations are that you should have a high degree of suspicion that the patient may bleed more than normal. Limit the use of crystalloids and permit hypotension. Call for help and involve other specialties. Use blood and blood products early in the ratio of 1:1:1. Early use of tranexamic acid is must, and consider fibrinogen. Manage other body systems, but most important in all, make your own hospital algorithms for such situations, because they arise suddenly and severely. Thank you. I hope I covered all the topics.
Very well covered, ma'am. Indeed, I think most of the things were covered. Only thing, and I really appreciated how very well you stressed upon the underestimation, or difficulty to estimate the blood loss that happens during these kind of emergencies. So for the postgraduates, if I may add the importance of obstetric shock index in this scenario, which is actually the heart rate divided by the systolic blood pressure. So if you're not able to estimate, or if you're not able to rely on a visual estimation, if we just divide the heart rate by the SPP, and if it comes out to be more than 1, so that itself is an indication that we really need to activate the help and the massive transfusion protocols and everything. The prognosis is indeed not very good. Other thing is the rule of 30, which we also usually follow, that when the systolic blood pressure has fallen by 30%, the heart rate has risen by 30%, respiratory rate has risen by 30%, and the urine output has gone down by 30 ml per hour. So it is approximate 30% of the blood loss that has already happened. And yes, definitely the massive transfusion, which can lead to the lethal diamond, which is in picture these days. Instead of lethal triad, we talk of lethal diamond. The acidosis that can happen with it, the hypothermia, and the coagulopathies associated with hypocalcemia that can happen because of the massive transfusion. Yes, I think.
Thank you, ma'am, for giving the additional information.
Also, ma'am, I would like to tell the postgraduates and the delegates about the restrictive fluid strategy that we discussed, which you very well discussed, because the practice is like to give fluids till the blood arrives. So again, the studies have shown that restrictive fluid management, even in the case of severe obstetric hemorrhage, has shown to have better, benefits in terms of post-operative AKI, mortality post 90 days, whatever studies have shown. So yes, restrictive and tolerating a little hypotension till we have the blood in hand.
Yes, definitely, ma'am.
Yeah.
Ma'am, thank you, ma'am, for all the input. And I'm sure the PGs have benefited from this. Done.
Definitely, I think. The next topic that we have is blood and blood components. And the topic will be presented by Dr. P.N. Shivpriya. She's an associate professor in RML Hospital. And her areas of interests are